Hi, Brandon.
Morning, Ritika, or afternoon. Hi, hi, Dr. Ajay. Nice to see you too.
Hello.
I can see that we have around 21 participants. Do we want to wait for a couple of minutes to just give everybody a head start?
Yeah, I'm fine for us to wait another minute or two. That sounds good.
Awesome.
Okay, Ritika, we can probably get started now.
Sure. Thank you so much for the heads up, Brandon. Awesome. Good afternoon, good evening, good morning, everyone, based on whichever part of the world you are joining us from. I am Ritika, and I'm working with George Washington University as a research consultant on mental health issues, specifically in Nepal. सबैजनालाई स्वागत छ in the second webinar of the Nepal Mental Health Research Series, where we'll be talking about mental health during COVID-19. Our speaker today, as you can see, is Dr. Ajay Rizal, and Professor Brandon Court from George Washington University will introduce the speaker, and lead us into the webinar in a short while. A couple of super quick housekeeping items before that. I would like to remind everybody, म सबैजनालाई याद दिलाउन चाहन्छु कि आजको हाम्रो यो वेबिनार रेकर्डेड भइरहेको छ. We are recording the webinar. हाम्रो यो webinarको recordings and presentations will be made available to everybody after the webinar. Ani super quickly, it is encouraged, we expect, we would appreciate it if everybody had questions for us after the presentation, because it is such an interesting topic. It is such a ekdam chaldo baldo topic sa mental health during COVID-19. So questions are anticipated and very, very welcome. Our chat feature is enabled. So त्यसमा any questions that you might have, please put it up in the chat. And once the presentation is complete and the discussion, we can begin the discussion. The floor is open for discussion. We will make sure that we address all the questions that you have. At the same time, as soon as the floor is open for discussion, you can simply raise your hand, and then हामी तपाईलाई floor दिन्छौं, and then we can further discuss anything that might be of interest to you as well. Super important for me and super important for all of us present here. हामीले towards the later half of the webinar मा हामीले एउटा feedback form तयार पारेको छौं, which we will put up in the chat as well. We would really like to encourage everybody to fill in the feedback form, mostly because it will help us make the webinar better in its other iterations. And at the same time, we're also planning to give out certificates of participation, and we will be in touch with you regarding that. But that you fill out the feedback form is a rather important thing in that regard as well. So feedback form चाहिँ कृपया भर्दिनु होला, हामीलाई त्यसले एकदम सहयोग पुर्याउँछ. It will be very, very beneficial to all of us in this process. One last thing from me. A lot of people who are here know that this is a series of webinars. So we have monthly webinars on the third week of every month, except likely October, किन भन्दाखेरि हामी नेपालीहरुको महान चाड दशैं हुन्छ त्यतिखेर जुनसँग overlap गर्छ. But this is not something that you need to worry about, because as in the previous times, we will be sending out invitation emails to everybody with the dates and speaker details, and with frequent reminders as we are likely to do. I would just like to ask everybody, यदि तपाईहरुले हामीलाई फलो गरिसक्नु भएको छैन भने चाहिँ ट्विटरमा, फेसबुकमा फलो गर्न सक्नुहुन्छ. You can write to us on the email address that is here. We will also be sending your slides पनि हामीले तपाईहरुलाई पठाउँछौं, so तपाईहरुले केही पनि टिप्नु चाहिँ पर्दैन, but you can always get in touch with us whenever you want to. And with that, it's over to you, Brandon. I'll stop sharing.
Great, thanks so much, Ritika. And I just saw a note from Yuvraj Ji in the chat. Yes, so the feedback form will both be posted in the chat here, and then we'll make sure that our colleagues at TPO who handle the email address send out this to everyone who's registered as well. And as Ritika was just saying, our hope is to get things in place to be able to provide certificates of participation for those who participate throughout the year and send in these feedback forms. I'm delighted to introduce Dr. Ajay Rizal. This is really such an important topic that we'll be discussing today. And I hope that Dr. Ajay's talk spurs all of you to contribute after and share some of your experiences and lessons learned in providing mental health responses during the COVID-19 pandemic, as well as potentially research that you are interested in or new research that you've identified that needs to be done as a result of this. So I've been able to see his slides, and they're very comprehensive, and I think it'll spur a really productive conversation. As Ritika said, please put any thoughts or thoughts in the chat box as we go along. So let me give a formal introduction to my colleague here, Dr. Ajay Rizal. He is Associate Professor in the Department of Psychiatry at Kathmandu University School of Medical Sciences and has been leading the department for the last 11 years. He's been working in the field of medicine for the last 15 years and has specialized in psychiatry a decade ago. His primary research interest is to work in the neglected field of mental health in Nepal, something that we are all very passionate about, where academic research in general and psychiatric research in particular traditionally has not been prioritized. And Dr. Ajay and many of you here are really on the front lines of changing that and making it more of a priority across the country. He's also involved, very importantly, in the cultural validation of psychiatric inventories, which are primarily in English and developed in English-speaking countries, and tailor those for use in Nepalese populations. And this is such an important issue because there's always a saying that bad data is worse than no data. And so when we use tools and we don't properly adapt and validate them, we come up with conclusions that might be misrepresenting a problem or an issue. So this adaptation of tools is so important. And I really plead for everyone to make sure that you're appropriately clinically and culturally validating, and turn to Dr. Ajay as an expert on that. So recently, Dr. Ajay has been involved in a number of collaborations focusing on geriatric mental health. He's published 44 research papers in national and international peer-reviewed journals, mostly as the first or the corresponding author. He writes papers both in English and in Nepali in the local media to help decrease the stigma related to mental illness, something we'll be talking about in future webinars, and improve the understanding of people on various issues related to mental health and advancing mental health literacy. So with no further ado, I will now turn it over to colleague and expert, Dr. Ajay Rizal. Thank you so much for presenting today.
Thank you, Brandon, for a good introduction. And I would like to thank everyone, to whoever is involved in this webinar series, to include me as a speaker. I am very much delighted to speak here regarding mental health issues in the current pandemic situation. So I will be sharing my slides. I hope everybody will. I think it is visible to you all.
Also, Dr. Rizal.
Okay, I have already been introduced. Now I am in Dhulikhel, Kathmandu University School of Medical Sciences. Currently, I am in Dhulikhel proper while delivering this talk. So COVID-19 and mental health, I'll be just highlighting the Nepalese perspective, research, as this is the mental health research series. So I'll be talking about research issues, in the last slides. So COVID-19 is not new now. It is already almost 2 years that we are suffering from COVID-19. Our family members are having PCR positive or COVID-19 status. And in the last 2 years, we have lost so many lives all around the world. So COVID-19 is not a new thing here. So now, since my talk is mainly devoted in mental health issues, so I would like to just give some earlier evidences regarding neuropsychiatric manifestations of earlier outbreaks, which were also related to coronavirus, like we had SARS, MERS, etc. In that also, we could see that there were certain neuropsychiatric manifestations. In the acute phase, they had confusion, depressed mood, anxiety, etc., etc. In post-illness phase, again, depressed mood, insomnia, anxiety, a lot of things. So the researches which had been done during those periods, during the period of SARS, during the period of MERS, we could see that in the later part of the pandemic, or when the pandemic has been finished, at that time, the most of the important psychiatric manifestations was post-traumatic stress disorder, almost in 1/3, depression in 15%, anxiety in 15%. So that was the neuropsychiatric presentations. Now, current implications, we have to say, I have already told, for last 2 long years, we have been suffering from there. So we have witnessed so many things which are very much important for neuropsychiatry, or very much important for psychosocial environment, like socioeconomic issues, medical issues, cultural issues, so many things. And still, in last 2 years, there are some studies which were telling whether all these neuropsychiatric issues are related to immediate virus effect, or just because of the psychosocial consequences, or whether just the natural adaptive phenomena is coming up with stress-related disorders like adjustment disorder, acute stress reaction, etc. For PTSD, still we have a lot of time. We need more research to go into PTSD, or it is another psychopathology related to COVID-19, or whether it is health anxiety, just a normal anxiety phenomena, or it is a pathological anxiety. Whether we have to deal with the recovering issues, or pathologizing again and again, pathologizing COVID-19 neuropsychiatric manifestation. So for coming to the conclusion, we have a lot of time still, because it is just 2 years. 2 years is very short period for coming for the psychiatric manifestations. Time may heal. That is the positive thing which we can think now also. But the ongoing researches show a lot of concern. So we need to be concerned regarding psychosocial manifestations of COVID-19 in Nepal also. So chances of higher rates of common mental disorders is found as the researchers show. So international researches, there was a meta-analysis which I came across, published in 2020. Again, it was similar to that earlier coronavirus infection, SARS, MERS, etc., acute stress, delirium, agitation, altered consciousness, later possibility of depression, anxiety, fatigue, PTSD. Symptoms related to anxiety, depression, or stress, psychosocial reactions, disturbed sleep were also seen. So one study, national survey data done in 3 countries, we can see that the distress, the level of distress among the population during this COVID-19 situation, in China, it was 35%, Iran, it was very much more, 60%, USA, 45%. All those are researches which was published in United Nations policy publications. So regarding studies in Nepal, in the last 2 years, when going through the whatever the research attempts happened, I just went to the NHRC, Nepal Health Research Council website. I could see that around 204 COVID-19 research proposals were submitted to NHRC for approval. So some researches are ongoing also. I came across the police report which showed that suicide rates is increasing in the COVID-19 era. Earlier it was almost around 13 to 14 per day, or 14 to 15 per day, but now it has come to 16 to 17, 17 to 18, 18 to 19 per day. So these higher suicide rates are increasing. That is also interesting, but it is just a police report. So we need to be a bit cautious to come into the conclusion with this. We need to have many researchers. I will talk about that later. And there are hospital level studies. In the fever clinic based studies, we could see higher rates of depression, anxiety, and stress. Again, so I myself happened to be the part of the research which did among the medical students. We could see using the scale like HADS Nepali version, culturally adapted scale, we could find the high prevalence of anxiety and depression among the medical students. Similarly, another study is done by Gupta et al. Among the health workers, they also showed anxiety and depression. This is also an important thing because health workers are suffering. And medical students, which we happen to do the studies, it was that medical students are the future doctors, future health workers. So increased prevalence of anxiety and depression among them is also one of the important issues. Similarly, post-peri-traumatic distress was seen higher level in one another studies. Poor mental health well-being, low sleep quality, high stress is another study. Similarly, severe psychological study is 13.3 percentage people had severe psychological distress, and another social impact, psychosocial impact among the Nepalese population was also found to be huge. So these are the studies which were which have been completed in 2020, 2021. Half we have finished. So this in this period we can see. So these are all similar to the studies, international studies report anxiety, depression, common mental disorder, distress, stress-related issues, etc. So what are the biopsychosocial factors? What may be the possible? So again, what I had said in the first slide, the biological, again, underpinning is that neurological manifestation of COVID-19 virus. Again, some studies have also shown that gene implications in the psychosocial issues of COVID-19, but that those studies are not conclusive. So I have not included that. Again, socioeconomic thing, because of lockdown, shutdown, whatever, the inequality, poverty, unemployment, whatever is happening, the socioeconomic impact may have another psychosocial underpinning. So again, last 5 months ago, we had high rate of COVID-19 infection, the so-called second wave. Now we are talking about third wave. During the second wave, we had witnessed lot of inadequacy among the health resources, inadequacy of oxygen, inadequacy of ICU beds, ventilators, all those things. We lost a lot of life, around 10,000, more than 10,000 life we have lost in Nepal. So it was almost related to inadequate health resources. And this loss of life with grief, adjustment problems, adjustment disorders, all those have also psychosocial consequences. Stress, social isolation, family violence, etc. are there, and physical activities reduced because children are confined to home. They are not allowed to. They have not got chance to go to the school, meet their friends, etc. Similarly, elderly people have also less intellectual stimulation because of the reduced physical activity. Maybe related to it is related to cognitive decline. Again, another mental health services. Nepal, we have already limited mental health services. We have very few psychiatry wards, inpatient services where direct supervision of psychiatrists or clinical psychologists are there, or psychiatric social worker is there. So the rehabilitation center, they don't have direct supervision. All those is still, there are already limited mental health services we have in Nepal. And what we had, we in our hospital also we witnessed that our psychiatric ward had to be turned to isolation center for the patients, for the patient family. So all those things, there are closure of mental health care facilities. And psychiatric patient, which we needed direct interview, direct communication, they were retailed with online devices, like online mobiles or Zoom meetings, etc. and messengers, Viber video calls, those we used for talking with our patients. So digital consultations. So all those have closure of mental health care facilities, which were converted to isolation and quarantine center. We had to rely on remote care. All those have substantial impact on already limited mental health services during the COVID-19 period. Similarly, those who were in regular follow-up with us, they they could not come to the hospital because OPDs were closed. So those who were getting regular medicines, they could not get medicine. So there was relapse, etc. All those had substantial impact on already limited mental health services in Nepal. So this was an important issue. This is the very important issue regarding mental health during COVID-19. Regarding the psychosocial concerns, there are a variety of concerns like health anxiety, unhealthy coping strategies, lockdown, shutdown, whatever name is given. Like in Nepal, we had like lockdown, banda bandi. We say in Nepal, it is a very new term in Nepal because I also came to know about this lockdown only during this COVID-19 period. Another is nisedagya, shutdown, whatever. All those are new things for us also. So they have psychosocial concerns, isolation and quarantine. So these are also for the infectious diseases. These are well-known term, but using this term frequently now in last 2 years has made very much important thing. And stigma and discrimination. This is coming down because earlier time in COVID-19, just like March 2019, March 2020, April 2020, in those periods, those who were COVID positive were stigmatized because in the house, in the gate, it was written COVID like a ghar, COVID bhayeko ghar, etc., etc. And even the doctors and nurses were not given the house for rent, etc. They were not allowed to use the public path, public way. And whenever the doctor or nurses passed, everybody used to turn their face, etc. All those discrimination were, we also faced those similar type of discrimination. And those who were COVID-19 positive, they were regarded as stigmatized and prejudiced, etc. Those, but now it is coming down because people are learning, because there is no house which does not have one or two COVID-19 in their family. So health anxiety, in some way, health anxiety is good. Bodily sensation, being aware of the changes in the health, being aware and then going for the help. For that purpose, health anxiety is good. It may be protective and natural way of coping in everyday normal life. But during outbreak, whatever, it becomes excessive and counterproductive. Inaccurate and exaggerated information from the media is generated. So people tend to have maladaptive behavior, repeated medical consultation, or avoiding the healthcare, not coming to the hospital at all. Hoarding particular items. We have seen in Nepal also, because hoarding oxygen cylinders, hoarding masks, hoarding other things, and then going to the shop and hoarding all the necessary eatables to the house, all those things because of the health anxiety. At broader societal level, like mistrusting, not trusting doctors, not trusting police, not trusting public authorities, or making someone as a baliko boka, scapegoating. So these are all the features of health anxiety. And unhealthy coping strategies, again, excessive use of alcohol, excessive use of tobacco, relapsing. Those who were abstinent started relapsing with the use of alcohol, and spending more time to potentially addictive behaviors. All these are unhealthy coping strategies. In order to cope up with the anxiety, in order to cope up with the depression, all those are things. So lockdown, it is now familiar. Because of the lockdown, there is reduced access to family, friends, social support system, leading to loneliness, anxiety, depression, problems in concentration, like financial strains, apprehension about future. Because of the lockdown, many people have lost their daily wages, etc. All those have psychosocial connotations. So isolation and quarantine, now it is interchangeably used, but for theoretically, quarantine is separation and restriction of movement of the potentially exposed people, and separation of already diagnosed contagious people is isolation. But it has been used interchangeably in the public communication. It should not bother much. So the studies have done during isolation and quarantine. What are the predictors of stress, like longer duration of lockdown? For example, earlier we used to have we used to be, I myself was isolated. I became isolated in the earlier November when I was COVID positive. At that time, until and unless I got the negative report PCR, it took around 21, 22, 23 days. Because of that, we had longer duration of isolation, but now we have changed that also. Principally, we have after 10 days, it is not necessary, something like that message is going on. So longer duration, when the isolation and quarantine phase is longer, the stress is longer, stress is more. Fear of infection, frustration, boredom, inadequate supplies, inadequate information. When you have to be in isolated in the government setup or other things, whether there is no lack of facility and financial concerns, all those are predictors of stress. And the studies have shown during the isolation, quarantine, the individuals may have post-traumatic stress symptoms, confusion, anger, etc. All these are issues, psychosocial issues related to isolation and quarantine. So vulnerable people, we all are aware of that. The first responder and frontline workers like us, doctors, nurses, security persons, or elderly people, those who have pre-existing health conditions, diabetes, hypertension, etc., children and adolescents, and pregnant and childbearing women. Earlier, they were more vulnerable because it was said that the lactating women should not be vaccinated or pregnant women should not be vaccinated. But now it has changed. The time we are learning more and more, we are being educated more and more. So that is making changes. And migrant individuals. Now, it is the general thing. This slide is just general thing. What has to be done? So we have naturally occurring psychosocial support system. Our culture is supportive. Eastern culture is more supportive. Our family bonding is more. All these are source of resilience, solidarity, and cohesion. So that has to be developed more and more. And quarantine and isolation, again, it has to be shorter duration, reasonable duration, because now we have said that 10 days, if there is no symptoms, after 10 days, you can come out. No need to do repeat PCR. So if you are symptomatic after 14 days, no need to do repeat PCR, you can come out of the isolation. So these are this being because of the education, because of the knowledge we are gaining, that is helping us. So the clear information, now information is becoming more clear and clear. Earlier, we didn't have enough information. So we were also not knowing. We were in chaos. So all this. Adequate basic supplies, now it is providing communication, entertainment, and nationally inclusion of mental health and psychosocial consideration in COVID-19 programs. We are doing that in our level. But government level also should see, like during COVID-19, post-COVID situation, mental health situation should be seen. And mental health psychosocial support should be widely available to the community. And building more mental health services will support recovery from COVID-19, because COVID-19 infection will go, but its cultural aftershock, its psychosocial aftershock will definitely have lot of mental health problems in the future, like post-COVID anxiety, post-COVID depression. All those will remain for a long time. We don't know. We are still not know how long the COVID-19 infection proper will remain. Even if the COVID-19 infection has gone out, has been wiped from the world, but the mental health aftershock will remain for long. So that is important thing. So that is that thing we need to take it. So what are the areas to focus? We have to focus on social determinants of health, because just keeping the COVID-19 under control, or just treating the infection, or just vaccinating is not enough. There are a lot of psychosocial determinants, so that should be taken. And community has a lot of roles. Interagency collaboration should be there. Just Ministry of Health is not enough. Now we need to employ Ministry of Home, Ministry of Education, etc., etc. So many things. Ministry of Culture, Ministry of Social, Ministry of Youth, whatever. So practical measures that promote self-care, that should be focused. So primary mental health and addiction care should be strengthened, because I have already told there are a lot of relapses. Even if we say substance use, lot of relapses. Our own patients who were in regular follow-up, who were abstinent, they have started relapsing. So, and data, again, that Brandon had already mentioned, that good quality data, that is necessary. Just making bullshit publications, or just making a few just line and just showing that, making people in havoc, like it is doing so many mental health. But if we have good quality of data, we have good research, then that will be enough. So specialist services should be enhanced. So some of us are involved in mental health psychosocial support care planning. So that we are doing. We are using telemedicine, digital healthcare, because that was just when the OPD was closed. We can't because the patient would call, then we would have video call, Viber, messengers, those were used. So that is important. And online cognitive behavior therapy or other type of therapy also we can plan. We are doing, but we can plan. So what we can do now? Public education, again, regarding psychosocial effects of pandemic, motivation for disease prevention and health promotion, and mental health should be integrated to all the available healthcare facilities, teaching healthy coping and problem solving strategies. So empowerment of the COVID-19 patients and their caregivers and healthcare workers, again, they are, our researchers have shown medical students have a lot of anxiety and depression. Healthcare workers have a lot of anxiety and depression. So we should have the provision for mental health care to the healthcare workers. So special care to vulnerable population, grief-related works. So that was the important thing during the second wave last year, we can say, but just 2 or 3 months ago. So if we go to the Pashupatinath, we could see so many fires and so many grief, and that also the cultural things, the grief resolution, the Nepalese culture, which provided lot of good mechanism for grief resolution that could not happen because of COVID-19. So all these grief related works are also important. So more and more research evidences should be generated. So just the focus is for the researchers. So this slide just to mention that what the future research avenues we have, COVID-19 related research. Currently ongoing studies, what I have shown in the earlier slides, they were mostly online, web-based and quantitative or cross-sectional studies, mainly focused on current and existing symptoms. And there was not much studies on stressors associated with lockdown, shutdown, quarantine related. I could come across just few meta-analysis, but that meta-analysis also not proper because only 2 years we have passed. This is not a time to do meta-analysis. So that was also only related to the past COVID infections like SARS, MERS. So we need to have studies on stressors associated with lockdown, cultural thing we have to see, grief-related works we have to see. No study to compare pre-vaccination and post-vaccination because in Nepal, just around 11% or 12% have complete vaccination. So we have a lot more to go for vaccination. So there is time to do for post-vaccination studies. So future studies should look into door-to-door survey, direct interviews, qualitative researches. So that is the focus. That should be the focus. So my thinking is also that we should go for as far as possible when people are vaccinated, door-to-door survey. It is very much essential for psychiatry. Just web-based study, just ticking the MCQ, multiple choice questions, that is not enough for generating the mental health research. So we need to have direct interview. We need to have qualitative data. We need to have in-depth interview. So in-depth analysis of past stressors, psychosocial issues is needed. And stressors should be elaborated. And post-vaccination studies also there. So these are the future research avenues which young researchers, which very much energetic researchers should look into. So these are the important areas. Just being patient with online studies or web-based studies, Google form generated data, that is not enough. So we need to go for more in-depth studies. That I want to highlight here. So yes, the COVID-19 situation is very much stressful and overpowering. Yeah, that is no doubt. But it has brought forward lots of challenges and opportunity. Now we have time to understand human behavior. We have time to learn the philosophy and rules of nature. And we have a lot of research opportunities. So light is always there at the end of the tunnel. So that is my message. Says we should not just be like COVID-19 had done a lot of bad things, etc., etc., etc. We should not be focusing on that. We should see that nature has given us opportunity to understand human behavior and learn its rules. So COVID-19 is there. It will remain still. Many years it will remain in the nature. But we should learn to move forward along with the COVID-19. That is the thing that is always there at end of the tunnel. Thank you. Thank you very much.
Thank you. Thank you so much, Dr. Rizal. We have a lot to thank you for. There was a lot to think about. There's a lot of food for thought here. Very interesting presentation. And most importantly, you were super on time. Please feel free, super quickly, you can either post questions in the chat box or you can go to reactions and raise hand. I can see that Brandon already has his hand raised. If you would unmute yourself and ask your question, please.
Oh, that was my clapping hand.
Oh.
Okay, just a minute. I will just turn on the light because it is being.
Ritika, I see some comments starting to come in, so you can present those to Dr. Ajay.
Thank you. Thank you, Brandon. We have a lot of thank yous, Dr. Rizal, and we have a question. How do we avoid feeling guilty or distressed when engaging in social activities function, even if they are as simple as going to the workplace or shopping?
Again, being distress is common. I don't think it is just a psychopathology. This is the time is like that. We can be distressed. We can be feeling guilty. There's a lot of guilt. But if we think about avoiding this being guilty or avoiding being distressed, we can't avoid that. But it should not affect our daily functioning. That is the thing. Because human mind is prone to be distressed, prone to be guilty in this type of situation. But we should not let this guilt or let this distress affect our daily activities. That is the thing. We should go on that. But if you find because of distress, because of being guilty, you find yourself being very much depressed, or this guilt, this distress feeling is overpowering you, then you need to have professional help. So there you can contact with the psychiatrist, you can contact with the psychologist. So these are the important messages we should do. But thinking about avoiding being distressed and avoiding being guilty will not help. So we can't avoid that, but we should not overpower.
Thank you, Dr. Rizal. We have a couple of other comments. I'll just read them out as well. From Dr. Court, we have, I really appreciated how you also highlighted the importance of qualitative research to really understand the situation, and that we can't simply understand the situation and what needs to be done if we only look at quantitative survey results. Yes, the importance of qualitative research is very much there. A couple of thank yous, and also another question, Dr. Rizal, are there any community-based studies conducted on COVID-19 and mental health? Most studies I have come across are among health workers or medical students. Who do you think are mostly impacted in the community?
Yeah. The community, that was the message I wanted to give, because whatever studies I just went through PubMed or went through Google, I could see the online and web-based studies, and mostly, yes, that is true, health workers and medical students like that. But community-based study, I didn't find much. So in Nepal again, there are very few, no community studies related to COVID-19 and mental health. So that was the thing I wanted to encourage the people for that. And health workers and must impact, I have to say that must impact is among the frontline workers, and they happen to be health workers, like our medical interns, our medical officers, our residents, whatever residents, because they were the one who faced a lot of people directly in front. So those were the most impacted. And we haven't done these studies, but we can see that the impact may be more among the other frontline workers, like security workers, traffic polices, and I have to say again, journalists. So these were the mostly frontline workers in this scenario. So they may be mostly affected, but we haven't found much studies in among the traffic polices, security persons, or journalists. So most of the studies are in among the medical students, mental health workers, and mostly they are online studies or Google form based studies, digital studies. We don't have community studies.
Thank you, Dr. Rizal. In case there are any follow-up questions, please feel free to put them up on the chat box as well. Super quickly, I have put up the feedback form on the chat box. Please make sure that you fill this up. And another question, I have been asked to prompt everybody that if you have not registered, you may, or if you're not a part of a network already, you may not be emailed the presentation and everything. Please reach out to us on the email address that I have in the chat box, which I will resend again, and we will make sure that you have all the materials. We have another comment. I'm currently doing a qualitative study among people with spinal cord injury, and many findings that Dr. Rizal mentioned resonate with what we found so far. Awesome. And impacts are even huge in people with disabilities. Thank you for the comment. This is very, very important. We have a raised hand. So Hardrai, please unmute yourself and go ahead.
Thanks, Ritika, and thanks, Dr. Rizal. That was very interesting. And I really wanted to highlight like what you mentioned about like the family members having a long-term mental health effect because of the COVID patients. And that's something I felt very personally. And I just wanted to like point out that like there's always a confusion about like if someone in the family members dies from COVID, then you have this long-term guilt of like being not being there for them versus like how do we keep ourselves safe. And then me and then my family members have been feeling that for a long time, right? So it's always that feeling of guilt or being safe and then keeping other members safe. So I think it's not only me, or it's going to it's among like a lot of us among ourselves as well. So I think like for other researchers or the people who are interested in that, that would be an excellent topic to work on. And then like you said about the psychosocial and the religious aspect of healing, and as well not being able to fulfill the religious rites and all of those things. So that actually impacts for a long time, right? So just wanted to highlight that, and then thank you for bringing that up.
Thank you.
We also have a raised hand from Drishti Guru. Please unmute yourself.
Thank you, Ritika, and thank you so much, Dr. Rizal. This one is for you or for anyone else here who could answer. So you did mention like a lot of other research are necessary in COVID, especially in the community. I was wondering, could you or others suggest any like research methods that can be used, alternative methods that can be used in the times of pandemic that are feasible in Nepal? Because I think we are kind of struggling with that at the moment.
We just whatever study I have found is just web-based study. Google, just we sent the Google form and in the link, and then those who were accessible and who were literate enough to participate in that of digital survey could do. Yes, pandemic situation is there, and we can do better than that. I think is telephone communication. At least we can speak to the person, the concerned. So telephone communications are using the like Viber videos or Messenger videos, etc. can be used. At least those who are illiterate also can respond. So what we do in digital like Google form, whoever has email address, we send. Whoever is able to work online and who are able to use the computers or the softwares, they were able to participate in that. But lot of the people are missing. So telephone communication we can use, or when the vaccination drive is like almost complete, 70%, 80% are vaccinated, then we can just have the safe distance, and then we can do door-to-door survey also. But what I find is door-to-door survey is the best interview-based method is the best for mental health researchers. So these are the things.
We have another one question, Dr. Rizal. Thank you so much for being so patient and answering everything with so much detail. We really, really appreciate it. Thank you, Dr. Rizal, for highlighting the mental health problems during COVID-19 and also showing the future research possibilities. There were data showing majorly concerned with mental health disorders, especially in particular group of people. But I was wondering if there were researches that showed the researches that how the COVID impacted the general population in their psychological state, not necessarily mental health disorders.
Yeah, yeah, that is true. That is true. But again, same thing. Whatever I had told to Drishti, same thing again. Because if we are doing the Google form-based study, so then we can have only the simple. We can use few questions. We cannot interview in depth. So for that in-depth interview, again, qualitative study is necessary if we want to know the detailed impact, not just going to the ICD-10 or DSM-5 disorders. Psychological health in general, if we want to see, we need to have qualitative studies. That is the important thing.
I also have a question. It is open to everybody. It's a very layperson question, so please bear with me. Over the past few months, I am an active user of Twitter, as I'm sure a lot of people in this call are. And what I have witnessed is that people are with so much interest and with so much lack of reservation, at least the urban English speaking people are sharing mental health issues online on social media. Like they're completely talking about facing anxiety, having issues getting up in the morning. Do you think that is something that can change the way we study mental health and look at mental health even? Do you think this will have broader implications?
Yeah. Again, yeah, it has a broader implication. Yeah, I also become happy whenever I see some in Twitter that they write a mental health issue. I just directly message to them, and then just I want to learn from them. So what is the issue? And then I introduce myself as a psychiatrist, and most of them, what I found is that they are either nurses or some way related to health work. The general public still are not willing to share their mental health issues. So in that case, yeah, that will help just to raise the awareness, to decrease the stigma. But again, the person who doesn't have Twitter or the person who is not digitally literate, they are again not able to come in front with that. But that is doing something, but not everything.
Thank you, Dr. Ajay. We have around 10 more minutes left. I can see that we have a question, and we also have Simone G. Her hand is raised. Please unmute yourself and put your question ahead.
Thank you. So I was wondering if there has been any research conducted on women, especially homemakers in South Asian countries, or even if like it's in India or Nepal, based on how the COVID-19 pandemic has hit them. Like, since there has been many researchers that indicate that domestic labor done by women have increased a lot. So is there any thing done for their mental health as well?
I haven't come across the research on them. So until and unless we start community-based research, we cannot have research on them. So that is important issue, yeah. But the newspapers and journalists, they have prepared the reports, but I don't know how much authentic is that. But we need to do the research on those issues. So thank you.
Thank you. We also have a question. Dr. Rizal, any thoughts on the effectiveness of mental health helplines during this pandemic? Has there been any study about this in Nepal or elsewhere?
I haven't gone through that. Maybe international researchers are there on that effectiveness of helplines. But in Nepal, we have a lot of helplines. Yeah, even TPO has a helpline for suicide helplines. Institute of Medicine has a suicide helpline. Mental Hospital in Logankel has suicide helpline. So the helplines are coming up, and that is definitely effective. I can say that, because even if we just talk about suicide also, we will have no suicide contract to the people who have done suicide attempt, admitted in our hospital. When they are being discharged, we just give them the number that if for no suicide contract, if they have any impulse or any thoughts regarding killing yourself or something, just call us. So that call will help. So Similarly, helpline will help. But I haven't come across any study which have done the effectiveness of helpline. So I can suggest a TPO if there are any person, TPO related person here. So that will be a good idea to do the research. Yeah, that is very nice comment.
That's awesome. Simone ji, I see your hand is still raised. Did you have another question? In which case you can unmute yourself.
Oops, sorry.
No worries. Technology has always been a boon and a bane in itself. Anyone has anything? Thank you. This has been such an action-packed, information-packed session. And Dr. Rizal, we definitely owe you some cold drinks for all the talking that you've had to do, which hopefully we can follow through in our promise as soon as the pandemic is over. I see a raised hand. We have Anubhuti. You may please unmute yourself.
Hey, thank you so much. Thank you, Dr. Rizal. That was very informative. I really enjoyed your presentation. My question is regarding participant fatigue, because we're doing so many research in the same population. They've already been through a lot. As a young researcher, I always wonder how to respectfully reach out to participants, especially since we're using the web-based, so a person's getting 10 surveys a day. So as a researcher, what are your suggestions on how to respectfully reach out to the participants and how best to conduct research in this environment?
Yeah, fatigue, important thing, yeah. Because I also, during the early phase of COVID-19, I was very much enthusiastic to conduct that Zoom-based things. But I'm also being fatigued actually. Those things I just want to cut. I just hope that some in-person sessions will happen, because even the classes, online classes we are doing, even our children are having online classes. So I was just wondering when the time will come that we'll have just in-person sessions or etc. Yeah, this is also good area. If we can think about that, let's develop some proposal. I'm very much enthusiastic to conduct the study regarding the fatigue among the participants, Zoom fatigue or online fatigue. So I'm also interested for that.
That's awesome. Brandon has also sent us a very helpful resource for anybody who is interested. Brandon has sent us a paper summarizing mental health issues and COVID in terms of responses and programs in low and middle income countries. So anybody who's interested, please go to the chat box and check out the link. Do we have any other questions? This has been such an invigorating session. And for anyone who doesn't know, it's almost 7 p.m. in Nepal. So kudos to everybody for your high energy and participation. Like I really appreciate it.
I just wanted to echo what Ritika is saying, and first say a huge thanks to Dr. Ajay for taking the time. I know how busy things are at the moment with your clinical work, your research, other activities. So thank you so much for preparing these incredibly informative slides and sharing your experiences. You've really sent out a great roadmap, I think, also for the future of research on COVID and mental health in Nepal. So I encourage you and others to continue to push that forward. Maybe you can put together kind of a top 10 priorities for the next phase of research after this pandemic. And I also appreciate all of the great comments and feedback and participation from everyone. Lots of really good points. And what's so heartening for me is it's a mix of kind of some methodological questions, but also very humanistic about acknowledging the experiences that many people are going through, the experience of family members, guilt, distress, moving beyond just clinical disorders to the psychological distress that everyone's feeling in different ways. So the honest conversation, I think, also is really helpful and keeps us grounded in this work. And I want to echo the last point that was raised too, just about how easy it is to have research overshadow, in some instances, care and services. I remember doing work in Liberia, and folks said, I've been interviewed by Harvard University, Columbia University, and Berkeley University about my PTSD, but no one has offered me any care or support at all in all of those different interviews. So many of you here are kind of dual-handed in terms of both doing research and clinical services or social services in some way. So you're a very impressive group. One last time, really would appreciate any feedback. As Ritika and I mentioned at the beginning, we will use these feedback forms to figure out a way to get certificates of participation for those that you regularly participate over a year. It will be provided by George Washington University. So please complete that. We would love to hear ideas for other speakers. If any of you are interested in speaking, send us some information on that, or others whom you would recommend. We really want to get a diversity of speakers here. And as Ritika said, our next meeting will be in September. We will take a break in October and then see you again pretty much every month for the remainder of the year and into 2022. So thanks again to Dr. Ajay. Thanks so much to Ritika and to TPO Nepal for organizing all of this. And I look forward to seeing all of you in a month.
Thank you, everyone. Thank you.
Bye.
Thank you. Bye. Thank you.
Bye-bye. Bye-bye.